doing surveillance is necessary, but understanding how these things work is also necessary so that we can assess plausibility.
So in our clinical trials, we are actually using relatively small sample sizes. And when we do that, we're at risk of tyranny of small numbers, which is you just need a single case of Wegener's granulomatosis, and your vaccine has to solve Walt's. How do you prove a null hypothesis? And it takes years and years to try to figure that out. So it's a real conundrum, right? Getting the right size, dealing with the tyranny of small numbers, making sure that you can really do it. And so I think one of the things that we really need to invest in are kind of better biomarkers, better mechanistic understanding of how these things work so we can better understand adverse events as they come up.
One of the additional issues that complicates safety evaluation is if you look at and you struggle with the length of follow-up that should be adequate in a, let's say, pre-licensure or even post-marketing study, if that's even possible. Because, I mean, one has to acknowledge the longer you follow up, the more you perhaps see adverse events that have nothing to do with the adjuvant vaccine combination, but maybe, again, coincidental. But the problem is, you know, how do you deal with that data? And again, as you mentioned, pre-licensure clinical trials may not be powered enough. It's also the subject population that you administer the adjuvant to, because we've seen data presented to us where an adjuvant, a particular adjuvant added to a vaccine antigen did really nothing when administered to a certain population, and it's usually the elderly, you know, compared to administering the same formulation to younger age strata. So these are things which need to be considered as well and further complicate safety and effectiveness evaluation of adjuvants combined with vaccine antigens.